Hello, everyone, and welcome to another Monday night at our show, Fresh, Natural, and Live. I hope you've had a great weekend, and I hope your Monday started off okay. Today, we have a very special guest, a good friend of mine, someone I've been working with over the years. We speak around the country, and we collaborate in different ways. And she's going to enlighten us about the issue of multiple sclerosis, as we refer to it as MS. And you may want to know what MS is. I'm glad you asked. I'm not a neurologist and I don't play one on TV. So I will let our guests enlighten us all on that topic. But before I bring her on, I want to bring our panel with us today. We have a light panel today. I'm working with a good friend and colleague, Dr. Celeste Palmer. Dr. Celeste Palmer is a pediatrician here in Houston, and she utilizes natural alternative approaches to helping her patients get well. She uses an integrative approach, and she has a great practice here in Houston. Hello, Celeste.
Hello. Thank you.
And so our special guest is Dr. Sarai Stancic. Dr. Stancic is a physician. She's the founder of the Stancic Health and Wellness Center in Ridgewood, New Jersey. And it's an integrative medical practice whose mission is to educate and empower patients to achieve optimal health via lifestyle modification. Her focus is shedding light on the building body of scientific data supporting the importance of optimal nutrition and disease prevention. The concept for this practice came in response to her experience as a physician for nearly 20 years and a patient with multiple sclerosis. So without further ado, Dr. Stancic, welcome. Welcome to Houston via digital link.
It's fabulous to be with both of you. And you have to mention that the way we became good friends and collaborated was you are a big part of our documentary film Code Blue, and your segment is extraordinary. It's funny, as the film is being broadcast across the country, I'm often asked about your segment. It's one of the favorite parts of the film. So thank you so much for being part of it.
Well, thanks for having me as part of it. And I want to let our audience know that they're having a big storm in New Jersey. So, if Dr. Stancic flickers out, she's not being rude. It's probably the act of nature. But we'll work on and go on. And she has her computer working and some backup plans. So y'all bear with us. So Sarai, we met a while back, and you have an incredible story, and you have a unique perspective. At least you came into medicine from a unique perspective. Rarely do physicians come in with the perspective of the patient. Now, of course, there's that syndrome where we all go through, and I think second year we're studying the pathology of things, and as we study things, we tend to get a feeling that we have the symptoms of what we're studying, but that's second year hypochondria. But other than that, you had a very special introduction to medicine early on in your career. So why don't you start there and kind of bring the audience and us from that point.
Okay. Well, I want to begin by telling you that by training, I am an internist, and I'm an infectious disease specialist, actually. Okay. And I went to medical school in the late 80s, early 90s, and regrettably that period was coincident with the height of the HIV epidemic. And I went to medical school in Newark, New Jersey, and Baxter, at that time, we had 2 wards of AIDS patients. So in one night, I would admit a cryptococcal meningitis, a PCP pneumonia, and a CMV retinitis. And at that point, we just would treat the opportunistic infections. We didn't have any antiretrovirals. So
I remember that.
That was my baptism, fire, and I wanted to be part of that solution. So the first 15 years of my career were really dedicated to the field of infectious diseases and really managing developing patient care models, and also developing research and medication. So I did a lot of research in developing molecules and treatments for HIV and hepatitis C. But the personal story is really what's put me on this path, and it is why I'm so passionate about lifestyle medicine and plant-based nutrition. And my story really begins in 1995, when as a third-year medical resident, I was on call at the hospital. It was a really busy night. I was literally running all over the hospital, and it wasn't until sometime in the mid-morning hours that I found an opportunity to make it back to the on-call room. I was so tired, I immediately fell asleep within a few minutes. Of course, within that busy call, I was paged yet again. And when I tried to get up at that sleeping position, I couldn't feel my legs. So it was that acute and that sudden. And that I was taken to the emergency room, and an MRI of the brain and spinal cord was completed, and a diagnosis of multiple sclerosis was made. And that changed, the course of my life, because at that point I was hospitalized, started on IV steroids, and then what I call, the parade of pharmaceuticals marched into my life. Before I knew it, within a few years, I was taking a dozen medications to, not only to slow the progression of the disease, but also to treat all the symptoms, the side effects of the medications that I was taking. So by the time I was in my early 30s, I was taking about 12 drugs. And despite all of those medicines, Baxter, my disease progressed and my quality of life suffered immensely.
So let me ask you, I'm sorry. You're on call, you're very fatigued, and things were progressing, and again, they made the diagnosis. So was there any one thing that really stood out in your symptoms, or is it just kind of the whole calamity of events?
Yeah, no, you know what? When I look back, I was diagnosed in 1995, but when I look back, when I was a medical student, I would have like little retrospectively, I can now piece it together, and it was probably, early symptoms of MS. Like if I wore heels, like my toes would feel a little numb, and I thought it was the heels, or I would feel tired, or, during an exam in medical school, I would have to go to the bathroom, to urinate like every hour, or, things like that. And then I would check and see, do I have a urinary tract infection? And I didn't. And this was because my, the bladder, I was having bladder associated issues from the MS. But, fatigue again, we're all medical students, and we're tired. And so I didn't piece it all together, but retrospectively, I look back, there were certainly signs. But on this night, I went to bed, and literally like 15 to 20 minutes later, when I got paged, I couldn't feel anything from my belly button down.
Wow.
It was like that. It was that acute.
So it's kind of it's almost like you went over a cliff.
Yeah, something happened. It was like building, and it was like the last straw that broke the camel's back, and all of a sudden I became grossly symptomatic. Yeah.
So you put on 12 medications. I just want to get a feel for that. I want to honestly get a feel for that. Were they treating? What were you told? Are these medicines going to cure it, or were they just sort of spot treating symptoms?
Yeah. So back then there was only one drug approved by the FDA for multiple sclerosis. It was the first drug called beta-seron. And so my doctor actually said to me, "You're like so lucky to be diagnosed now, because this drug was just approved. So you're going to gain the benefit of this drug." But here's the thing. This was a drug I had to inject every night.
Ooh. And
I would inject the drug at 10 o'clock at night. And then at 2 o'clock in the morning, I would awaken with like violent shaking, chills, fever, nausea. It was the worst thing imaginable. And of course he would say to me, "It's going to get better over time," but it really didn't. And so when I went back to see him after taking the medicine for a couple of weeks, and it was intolerable, he said to me, "Look, you have to remain on this medicine, because if you don't, you'll be in a wheelchair within 10 years. And, if you're 28 years old and somebody tells you that is the most frightening thing, and you'll do whatever they tell you." So he said, "Look, what we need to do is treat the side effects of this drug with other medications," right? So I couldn't sleep. I had insomnia. So he gave me Ambien. And then I couldn't wake up. So he gave me Provigil. And then I became depressed. He gave me Prozac. And then there was a drug for my bladder, a drug for the neuropathy. I had a pill box, so I was, a 32-year-old woman walking around with a pill box and a cane.
Was the first a steroid? Was the first drug a steroid?
So steroids are what we use to treat an exacerbation. So yes, I was given Solumedrol for 5 days IV. Okay. But that's what you use to treat the exacerbation. the drugs that we use, they're called disease modifying therapies. And back then when I was diagnosed, there was only one drug available, but now there's about 12 to 13 drugs that have been approved by the FDA, but these are immunosuppressive regimens.
Okay.
Wow.
So for example, one of the leading drugs that we use, Thyself, one of the black box label on this is that it can cause PML, progressive multifocal leukoencephalopathy, something that we see, that I used to see in AIDS patients when they were severely immunosuppressed.
Yeah.
So, it's a rare side effect, but still, it's frightening. I mean, we're treating, multiple sclerosis is an autoimmune disease. So obviously, an autoimmune disease is where your immune system, which is supposed to protect you against bacteria, virus, infections, foreign invaders, it's confused. Your body's confused and starts to attack you, right? So in multiple sclerosis, it attacks myelin, which is that fatty sheath that protects the nerves of the brain and spinal cord. And so the beta seron, which was the disease modifying therapy that was assigned to me, was the medication that I would have to inject every day. And it caused, fever, chills, muscle aches and pains, nausea, vomiting, diarrhea, anorexia, injection site reactions, depression, suicidal thoughts. I mean, this is just, some of the side effects that are routinely experienced. So it was about trying to manage that side effect profile, and the way to best do that, according to the multiple sclerosis expert that was my physician at the time, was to treat it with additional medicines. So I can tell you that I followed the conventional approach, and I followed what these experts were advising me to do. And again, I was a compliant patient, and disease worsened over time to the point that I was dependent on a cane or crutches. And then
did you feel worse? Let me ask you, when you started these 12 medications, did you feel worse on the medications?
Yes.
Versus off the medications? I mean, I know that, MS is a bad disease, et cetera, but if you could, I don't know if you had a good juxtaposition, but do you recall how you felt before taking those 12 medications, and then after you started taking, do you recall feeling better or worse?
No, I felt worse. But that was the way he explained it to me, is that this is something that you need. This approach is necessary because this is the only way we know to slow the progression of the disease. And if you don't take this medication, this disease will run its course, and at the time when I was first diagnosed, there was a significant burden of disease on the imaging, on the MRI. So he said to me, based on what I'm seeing here, you can expect long-term care, the need for long-term care. You can expect the need for a wheelchair before you're 40 years old. So, so all of a sudden this is the last thing in the world that I expected. I was 28 years old. I was just, had just been chosen to be chief resident. I wanted to go on to do gastroenterology. That was really my first choice. But then I was told, you don't want to do a procedure-oriented subspecialty. It was a very, very difficult period in my life. In addition to all the symptoms that I was experiencing and all the loss, because multiple sclerosis is a really frightening disease, because you can feel okay today, and then like tomorrow you can wake up and you're blind in one eye, optic neuritis.
And the medicine didn't really give you a guarantee. What did they? He said that it was only going to prolong your time from the wheelchair. Really? Is that what their thinking was?
Right. It's not a cure. The best it could do is slow the progression. Right.
Gotcha.
Slow the progression.
Yeah.
So
we hear that a lot with autoimmune diseases. In general, you basically just slow the progression, and
right.
certainly with heart failure, that's all we do: slow the progression.
Slow the progression, right? So there's no cure. There's no cure. So the idea is to slow the progression and reduce, the time to disability, right? Because you want to extend the ability for the individual to be able to, walk and have good quality of life. So, So he said to me that this was the best approach, and clearly based on the literature and the scientific studies, that this was my best. This was going to offer me the best chance to remain, able and active. So, but it wasn't working for me. I got to tell you, just injecting the drug, the pain from the injection site reactions and the SARS and the nodules, just the shaking chills. I would wake up with like these like violent shaking chills, the fever, loss of appetite, and I think one of the worst things is just not being able to sleep, and all of that, just depression and sadness. I mean,
So break down, Sarai, break down for our audience. So you did a beautiful job of kind of giving your story, and I think you've given a lot of this in terms of your experience and what have you. And I want you to get through some of the things that how you've conquered, because obviously, you're not suffering from those things now. But if you can, as Dr. Stancic, break down for our audience, some of the things, that they can look for with MS. Give us like some of the epidemiology and some of the things like that. Who's at risk, if anybody? I don't know. And what are some of the things that I know, lack of sunshine and various things, but what are some of the things that we need to think about for the MS?
So multiple sclerosis, it's interesting. It was thought to be that there in the United States, there are about 400,000 individuals affected with multiple sclerosis. But most recently, an article was published, I think about a year ago, and actually that's an underestimation. It's about 1 million. In the United States alone, and we see this disease most commonly in women, and typically in early in life, in their second and third decade of life. So typically you'll see a 20-something-year-old female who presents with some symptomatology, might be like some numbness or tingling or some weakness in an arm. Another very common initial presentation is optic neuritis, so blindness or blurring in an eye. That's another one that is routinely seen. And typically, and there's different types of multiple. I mean, I'm not a neurologist, but just based on my experience as a patient, we have relapsing remitting multiple sclerosis, which is the most common. So relapsing remitting says you have an exacerbation and then you get better. You sort of get back to baseline. And so it's sort of like, gets better, gets worse, gets better, gets worse. And typically when you have an event, it's called an exacerbation. And then that event is typically treated with a course of steroids.
What are some of the things that typically tip someone over into an exacerbation? I don't know, what was your experience or what have you seen in patients?
Right. Good question. It could be an infection. It could be a lot of stress. One of the risk factors for multiple sclerosis are vitamin D. Low vitamin D levels have been shown to be a risk factor. We know that individuals who smoke are greater risk of MS. Excess weight, obesity, overweight. There was this suggestion that, again, because of sunlight, like there are certain countries that you see the Scandinavian countries have much higher rates of MS, like Norway has one of the highest rates of MS. And actually, Norway is of importance to me because, and I can sort of backtrack and help you to understand how it came that at some point I came to the conclusion that I needed to implement changes in my own life is when I came across an article written by Roy Swank, who was a physician in the 1950s, who was really interested in MS, and he started to investigate the country of Norway because it had one of the highest rates of MS. And when he studied what was happening there, he noted that the highest rates were occurring in the inner farming dairy community. They were consuming a lot of saturated fat. So Swank in the 1950s, based on what he had seen in Norway and other countries in that area where there were high rates of MS, he hypothesized that saturated fat consumption was playing a role in the increased incidence of MS and even in worse outcomes. So Swank didn't just leave it at hypothesis. He actually started treating MS patients in the 1950s with a low-fat plant-based diet. And he followed 140 plus patients over 20 years and published his data in the Annals of Neurology in 1970. But he actually didn't stop there, Baxter. He followed them an additional 14 years.
Mhm.
And so at the end of the day, he followed these 140 patients over 34 years and published his findings in the Lancet in 1990. And he found that his patients who remained compliant with this low-fat plant-based diet,
Mhm.
they had much less mortality and morbidity. And in fact, 95% of them remained disability-free.
How do I spell his last name, Dr. Swank?
Swank.
Okay, Dr. Swank. I'm going to look that article up.
Yeah.
I think McDougall may have talked about him. Someone I remember speaking about him.
Sure. And actually, McDougall knew Dr. Swank. They were actually good friends. And actually, Dr. McDougall recently invested in a clinical study that was done in Portland, Oregon, at Oregon State University, where they actually did a study on recently. Because Swank was criticized for one reason, that he didn't have a control in his study. Yeah, so he used a historical control. So McDougall actually did a study. It's a small study. It was a pilot study with 60 patients. Half were randomized to a plant-based diet, and what he found, regrettably, he wasn't able to find a clinical difference, but he was able to show that those who consumed the plant-based diet had significantly less fatigue, which is important because that's the most common symptom that MS patients report. And the MS patients who consumed the plant-based diet had, on average, lost 20 pounds in that year of being on that diet. Mm-hmm. And also their cholesterol levels dropped by 20 points. And, believe it or not, cholesterol, I mean, we don't think of cholesterol in MS very often. We think of it in your line of work, right, in cardiology. But actually, there's a paper that was published that showed that as cholesterol levels climb, MS outcomes worsen.
Well, cholesterol, Colin Campbell has associated with cholesterol elevation in cancer.
Yeah.
In some of his data in the China study. And also he had some correlation with cholesterol elevation. And we had a conversation online, and he shared some data on the antiviral effect of plant-based diet and hepatitis B. And he also showed a correlation with cholesterol there. I think cholesterol is more of a signal.
It's a biomarker of inflammation, right?
Inflammation.
Yeah.
I think it's biochemical imbalance. I mean, it's a biochemical imbalance. So that's an interesting thing. But it's interesting. So Dr. Swank started getting results back in the 1950s. Did I hear you correct?
Yes. The original paper was published in the New England Journal of Medicine in 1952.
Wow, that's amazing. And it's really crazy that it's criticized that you don't have a control group and you're getting results that are this impressive with patients with such a debilitating disease.
Yeah.
So testing a gunshot. So anyway, so back to so the physiology. So it's autoimmune, associated with low vitamin D, lack of sunshine. Young females often presenting with neurological symptoms, optic neuritis being one. Fatigue is a very common one. Dr. Swank showed lots of evidence. One of the things, you mentioned cholesterol. Is there a imaging study or a biomarker that one could follow that could be correlated with symptoms with MS?
Well, that paper on the cholesterol, the physician who wrote that paper, I think her first name is Bianca and her last name is escaping me, but she's at the University of Buffalo. She proposed that potentially cholesterol could be used as a biomarker of disease activity in MS. But routinely in clinical practice, what is used to follow the disease is near yearly for many MS patients is an MRI, right? So an MRI with and without gadolinium, so without contrast. And this is, these studies are really very sensitive, and they're done very, very regularly. I don't have MRIs done any longer. I did have an MRI done for the film, just to show my progression, but I don't do them anymore. But I think in clinical practice, most MS specialists will routinely do MRIs, depending on how, because the need to do the MRI is really, if you have, for example, a patient who's stable, who's asymptomatic, and maybe is on a disease modifying therapy, there's no need to do an MRI every year. Typically, you'll order an MRI when there's a change in clinical status, or you're trying to decide whether or not you're going to start a disease modifying therapy. So, I think it's an individual decision that's made for each patient.
Okay, and then other markers of inflammation like SED rate or CRP, are they helpful or not?
Yeah, they're not in this setting. I think it's tough. Multiple sclerosis really, even though cholesterol has been proposed, it's not by like clinical guidelines don't prescribe that approach right now. It's just it's more really a scientific finding and a finding of interest. That as these cholesterol levels, I mean, to me, cholesterol is a biomarker of inflammation, of something's not right. Obviously.
Agreed. Yeah.
And I think it's interesting in the work that she showed, this physician at the University of Buffalo, whose last name is escaping me, that there's this correlation that you see as these cholesterol levels, increase, that patients have worse outcomes. So going back to McDougall's study, it was actually the study was done by Vijay Yadav, who's in the film. She's the neurologist that does my MRI and reviews my film in Code Blue. She's a brilliant neurologist in practicing in Portland, Oregon, and she practices in the same hospital where Swank was once chief of neurology. So it was very cool to be there and to see his office, and because to me, I mean, Swank was really a lifesaver, because it was that study that really sort of put me on this path, like for the first time, because I didn't learn anything about, as I'm sure you didn't either, I didn't learn anything about nutrition and lifestyle when I was in medical school.
But his data was published in the New England Journal. These are not,
and Lancet.
Yeah. I mean, now they've had some shady stuff recently, but put recent issues aside. But these are top notch. Why didn't your doctors know about this data? You were being treated by.
They didn't actually. So when I uncovered all of this, because it wasn't, and you know what, it wasn't just Swank. There were several other articles in other countries, in Canada where there's high rates of MS. So I made copies of all of these articles, and I went to meet with him because I was convinced that this could potentially help me, because I was in really a bad place. I mean, I'm 32 years old, wearing a diaper and walking with a cane. This is not good. So I was going to support. And so when I went to him with this, he said, Sarai, do you really think that changing your diet, is going to change the course of this really complicated neurologic autoimmune disabling disorder? It's not. Please just remain compliant with your medicine as prescribed.
Dr. Stanford, where can you kind of put a timeline for me? Like, where were you in medical school at this time? What year was it? And how long did you take the medicines before you kind of said this isn't working? So
I was a third-year medical resident.
Okay.
Third-year medical resident, and I took the medicine for 8 years.
Oh, wow. Okay.
So it was from 1995 to 2003.
Okay.
So 2003 is when I came across the Swank article.
Okay.
You took this data to your neurologist, and he looked at it and says, "This is what, hogwash or what?"
Yeah, pretty much.
Oh my goodness! It's really, oh gosh, and it's. I mean, I'm acting like I'm shocked. It's not like we don't see it all the time now. I mean, but it's. I mean, I guess I just get a little ruffled under the feathers, if you will, every time I hear stories like that. I hear similar stories from my patients. They go back to the doctors and say, well, this is what I'm doing. And so that's crazy. And I don't know. It's, I think many of us have chips in our brain, and we're programmed to not think outside the box. I don't want to be critical of our colleagues, but it's just heartbreaking to know. I mean, there you brought scientific art. It's not like you brought, just random data from some guy.
I didn't rip out a page out of Cosmo magazine, right? I mean, it's
exactly. So it's So the fact that it was ignored simply because it wasn't just some new drug or whatever, it's just, mind-boggling and more frustrating than mind-boggling. But what was so basically you took it to your urologist, he said you're crazy, it's not going to work. So what was your stance? How did you feel at that time?
Well, I was really, I had a lot of hope walking into his office, and all of a sudden it was gone. He really, because it wasn't just, no, this is crazy. It was like almost like it was like humiliating. It's like, why? How could you even think this could help you? But I started to think more about that his conclusion, because he ultimately said to me, if you want to blame anything for having MS, you can blame your genes, because that's why you have MS, and there's nothing you can do about that, right? So. Yeah. I started to think more about that, and if you look at the evidence in the literature, if you look at, for example, monozygotic twins, right? If twin A has MS, what's the likelihood that twin B will have MS? So that's what we call concordance rates, right? Mm-hmm. And so if you look at the literature tells us it's not 100%. It's not even 50%. It's more like 14 to about 30%, right? So it wasn't just my genes. Yeah. And again, it was for me like looking into the research and really trying to understand and characterize what was happening here. So as I did this research and I looked more and more, I came across the science of epigenetics, right? And epigenetics, which was first described in the 1950s and really sort of evolved in the 1980s, but essentially tells us that gene expression is dependent on outside variables, right? So that's the difference between genotype and phenotype, right? Just because we have a gene that predisposes us to something doesn't necessarily mean we will get that disease.
That's exactly right.
I'm sorry?
No, that's exactly right. That's an important point. I have that discussion with my patients all the time. And what I tell them is say your genes, your genetics is a blueprint.
Exactly.
And the expression is like the contractors that take that blueprint and build the house.
Exactly.
If you don't have the contractors to express that gene or to build that house.
That's a great analogy. I love it.
It just doesn't work. And so what you have to do is you've got to fire those contracts, that lifestyle oftentimes, and you don't express that house. Or if the house starts to get built, you fire the contracts and tear it down. Exactly. And that's where lifestyle comes into play.
Exactly. So great. And with the variables that are important, of course, in epigenetics are diet, exercise, stress, sleep, smoking.
We
talk about in lifestyle medicine. So, in 2003, I had like this, aha moment, this moment, epiphany that I was like, oh my God, I have all of this evidence here. Okay, maybe I'm not going to get the support that I so desperately seek to receive from my doctor. But, I'm a physician. I've thought this through really carefully. And I decided in 2003 to make a very unconventional decision that I was going to taper off of every one of those medicines. And instead, I would optimize every aspect of my lifestyle. Now, this was not a popular decision. Everyone tried to talk me out of it, including my family and friends. My husband's a physician. Ultimately, he was supportive, but he was very nervous. I mean, I understood there was risk here, but here's the bottom line. What I said to him is, my life right now is so uncomfortable and intolerable, having to take all of these medicines. My quality of life is so poor that I'm willing to take this risk. And I'm going to give it 100%. I believe that this could potentially help me. So I'm going to forge forward. So in 2003, I adopted a whole food plant-based diet. And people always ask me, well, why did you do that? Why didn't you do like a keto diet or a paleo, I don't know, whatever was popular at the time? I mean, I adopted a diet rich in fruits, vegetables, whole grains, legumes, nuts, and seeds because the scientific literature pointed to a diet that was a plant-based diet was the optimal diet not for MS or for diabetes, for heart disease, but for all of us. It was the optimal diet for optimal health.
And the thing is that I just want to pinpoint this. I think you alluded to it, but the data the findings that Dr. Swank had in his study, his outcomes were better than which was found in the drug. Is that correct?
Well, at the time, remember
There's no head-to-head comparison. But what I'm saying, he had to kind of do a meta-analysis in terms of this population. His population people did ran the mile in 6 minutes, and the other people couldn't make a mile. I mean, if you had to compare, I know it wasn't a head-to-head comparison, but looking at Swank's outcome,
historical controls. But remember, there were no treatments available back then. The first drug was approved in 1995. So he wasn't comparing his approach to like a disease-modifying therapy because there was no treatment. For MS patients, there was no treatment. So you just use supportive measures.
But is his patients? Did he get some patients who had cures? Or did he get some patients who, or did most of his patients avoid the wheelchair? I mean,
95%
avoid the wheelchair. Well, so 95% avoid the wheelchair in his group. What would you guess would be the percentage of people avoid the wheelchair in the drugs?
Currently now?
Yeah.
I don't.
I know you're not a neurologist.
Yeah, but it's not 95%.
Yeah, and that's what I'm getting at. I mean, and we see this a lot. I mean, I look at it with my heart failure patients. When I put them on nutritional detox, the EFs get better, and they go from 25% to 50%. We don't see that with medications.
Yeah,
most of the time, at least not in a high percentage of the time. So I was kind of alluding to that. I know that's not a head-to-head comparison.
Yeah.
He had 95% of people avoid the wheelchair. And with the drug studies, I would imagine they weren't seeing that high success rate. So even that's an indication, plus they felt worse probably compared to the food. But anyway.
Yeah, right. And the and remember, these medications, even if they have some decent efficacy, they have significant side effect profiles, right?
Yeah.
So you have to weigh that out.
Treatment can be worse than disease. So I'm sorry, I cut you off. And you're at 2003, and you take this challenge. Everybody's nervous, or your husband's nervous, and everybody else against you.
My mother's like calling me every 15 minutes. Are you okay? Yeah, everybody's nervous. Everybody's except me, because what I was living was so bad. I just wanted to be off of all of these medicines. What was one of the hardest things to do was learning how to sleep. Because I was addicted to Ambien, like hypnotics or Ativan, or I didn't know how to sleep. Wow. So coming off of Ambien was really, really hard, and like creating understanding what sleep hygiene is, and creating an effective environment in my home, and understanding, good like pre-sleep rituals, understanding the importance of temperature in your room, like all of these variables that I had never considered. But I learned that, and that's So
tell us about that hygiene, the sleep hygiene. Walk us through that real quick. I mean, listeners may not know about that.
So your environment, so it's really important that your environment should be cool, dark, and quiet, right? So you should, and the Sleep Foundation says we should have our temperature in our bedroom somewhere between like 67, 68. So it should be a little cooler. You want to invest in like blackout shades. There should be no light seeping into your room, because light, when the retinal ganglion cells pick up light, that interrupts the communication with the pineal gland, which produces melatonin, which is our catalyst for sleep. So you don't want any. In fact, as the day progresses, you want less and less light in your environment. Like when you wake up in the morning, lots of light. Let that sunlight hit your face. But as the day progresses, less and less light. Right, getting you ready for sleep. So cool, dark, and make sure your bedroom is quiet. Make sure you don't have computers or iPads or iPhones in your bedroom. They shouldn't. No television in your bedroom. Anything that is illuminating or giving, particularly this blue light, is really detrimental to sleep. Right. And then things like taking a nice warm shower before you go to bed, or massaging. I like to put some like lavender hand cream into my hands before I go to bed. And I, if you want to use prayer, or I think meditation at the end of the day, or prayer, something to offer gratitude. I mean, these are what we call pre-sleep rituals. And also the most important thing is creating structure around your sleep, right? So we know that the people who sleep the best and most effectively have structure. That means you go to bed at the same time every day and you wake up at the same time every day. And in between those two times that you pick, 8 hours. Okay. So people tell me, oh, Doc, I only need 5 hours. I only need 6. No, we need 8 hours. Okay?
You're making me feel bad here. You know,
I'm saying this on purpose for you because I know. Having spent time with you in Houston, I know exactly what you do.
Now, this is one. I'm taking notes here, so I'm taking notes. I'm being a good student. Now, this is great. Now, you mentioned no phones and TV. Obviously, you know, I sometimes have patients in the ER and all. I keep my cell phone on my nightstand. There's no light on. Is that okay that it's there in case I have to answer a call?
Well, of course. I mean, obviously, when you're on call, you have to. But I mean, don't do this. Like I know you're doing this too. You're in bed and you're checking your text messages and your email and all that. You can't.
Not anymore.
Okay. Our bedroom is for sleep.
Now, here's a great question. Zorro wants to know about naps, afternoon naps. Some people talk about taking naps. Now, if I were to take a nap, then I'm not as sleepy at night. I may not sleep.
Yeah, so I don't like naps. I think what we need to do is be productive and during the day, and then but we go to bed. Like, you know, you told me that this interview, because I'm in New Jersey, so here it's 8:42, and my bedtime is actually 9 o'clock. So I should be in my shower. Anything, Baxter. So
no, this is great. So this is great. So okay, no naps, Zorro. Now, so it's wonderful. So now you the sleep hygiene, your diet, and now let me ask you about medication weaning. I'm gonna have you take us through the chronology in a minute, but you weaned your own medications?
I did. Yes, I weaned off of all of them. Yes.
Wow. So take us through the chronology. So you started one day. When did you start noticing a breakthrough? Yeah.
So, it wasn't. I should say this. It wasn't just my food and my sleep, right? I started to exercise. So you know, this is important, Baxter. You know, in the 1990s, it was falsely believed that exercise worsened multiple sclerosis. So I was advised not to exercise.
I remember you said that in the documentary. Yeah.
Yeah. So for 8 years, I hadn't done anything. So I was really very deconditioned. So the only thing I could do safely, you know, without hurting myself, was a stationary bike. And my husband would have to help me to get onto it.
Okay.
And I could do like a minute or two, and then exhausted and in pain, he would carry me off, and it would take about 10 to 15 minutes to recover feeling. And it was like tingling and pain. For those 15 to 20 minutes, I would drink water. The other thing is, in multiple sclerosis, when your body temperature goes up, you become symptomatic.
Ah. Now, what's the mechanism there? Is that, I don't know, is it triggering your autoimmune system or?
Well, you know, the connections, those you know, where there's damage. And so myelin allows those neurological synapses to travel, you know, smoothly. So when you have MS, you damage myelin. And so the transmission of the nerve is not smooth.
Yep.
So when your body temperature goes up, you become very, very symptomatic. So anyway, I would do that minute or two, and then 10, 15 minutes. But the next day I went back on and I would do it again. And I was very, very regimented about doing it. And it seemed like, wow, you know, you're doing a minute. And I did a minute for 6 weeks, and then a minute and 15 seconds. It was very, very slow. And so the progression it happened over weeks and years, you know, months rather, that I started to, and at first it was like small, subtle things. Like I could stay up past Jeopardy, which was, I know that sounds crazy, but it was something like that. One day I remember getting to my office and feeling like, you know what? I don't need the cane today. I feel good enough. I'm going to leave it in the car.
Wow.
You know? And then there's one day that I always talk, it's in the film, and I have a slide, which was July 2nd, 2005. It was 2 years into my lifestyle change. I attended a wedding, my friend Tim's wedding. And that's why I remember the day, and that's why I have a picture of it, because I did 2 things on that day that I hadn't done in a long time. And to me, it was like amazing, because it was 2 things I didn't think I would ever be able to do. And it's going to sound really trivial and stupid to you, but to me, it was really big. I wore heels and I danced with my husband.
Wow. And that was in 2005. 2 years after.
2 years after my lifestyle change.
Wow. But you were dancing. Go ahead. I'm sorry, Celeste.
How did you know? Because the literature had given you information about the plant-based diet, but how did you know exercise with it feeling so bad? You know, a lot of times when we exercise, you know, we get positive feedback. You know, you feel better after, so you're like, you know what, I need to go back and do that tomorrow. But with you feeling, you know, struggling through it, how did you know the exercise was?
Because, you know, in 2003, by 2003, there was some evidence in the literature that spoke to exercise being beneficial for MS.
Okay.
So I started to, and I was so fatigued and so short of breath from just doing very little in terms of walking, that I knew I needed to build my stamina and my endurance. So yes, you know, but it was scary, because I would exercise and then I would be symptomatic and it would hurt. But for what I was convinced that I was going to work my way through that. And, you know, surprisingly today, I can go for a run and I can go on a bike and my body temperature goes up and I don't develop those symptoms.
How often did you go to your doctor during this time when you're kind of doing this on your own, or did you?
I didn't. You know, I think he was not happy with me, so I didn't feel comfortable going back. But, you know, we've mended fences since. It's okay. But
wow. So has he? I mean, you say he's mended fences. I mean, my goodness. First of all, in 2005, you danced, you wore heels. Was that the breakthrough? Does that kind of got you?
Then things just continued to get better. I mean, ultimately I ran a marathon in 2010. Right.
Wow.
So you know, so that's really my arc. You know, I was, you know, once dependent on a cane to run, you know, crossing the finish line at a marathon. So, and of course, I began my change in 2003 and I ran the marathon in 2010. I think a lot of people, and this is important, that this is not a quick fix. This is not something you do for 2 weeks or a month. I mean, I've had patients say to me, you know, I've been doing what you said for a month, and how come I'm not running marathons? It doesn't work that way. So you meet me, and then I show you a slide. Here I am with the cane, and then I show you me but there's 7 years in between those 2 pictures.
But it takes that long for some people without MS. My goodness. I mean,
exactly. And the other thing is that this is not a diet, this is something that I want people to adopt for the rest of their life. You know, this is a lifestyle change, and I don't want you to do this just because you're sick or just because you have MS. I want us all to do this, because when we all engage in these healthy lifestyle behaviors, we're going to live to our greatest potential. We're going to age gracefully. We're going to avoid developing a chronic disease. And, you know, Baxter, my hope for all of us, right? Because I mean, I've been practicing medicine for 27 years now, and I've seen a lot of pain and suffering. You know, as an infectious disease physician, I saw one diabetic foot ulcer after another, one pneumonia after another, one stroke patient with a nosocomial infection intubated. I mean, these are the things that I saw every day. And then the nursing home consults that I would see, the demented patient with the UTI, contracted, unable, doesn't even know I'm in the room. Listen, this is what I hope for all of us. I want us all to age gracefully, live to our greatest potential, and avoid that bookend in the nursing home, all that suffering, all that loss. And it's not just you who suffers, it's everyone around you who loves you, your family, who has to witness that period of loss and pain. And so we can all do this and just live joyful, healthy lives. It's just that regrettably physicians aren't speaking to this, and that's what we need to change.
I'm glad you pointed that out, because oftentimes patients are, well, you know, you trained your lifestyles well, I want to enjoy my life, so I want to eat bad food. But what they don't understand is that
that's not joy.
You're not going to die necessarily. If you have that stroke or you have that progressive chronic illness, you are going to linger in suffering. And you won't be able to enjoy that terrible food that you think you like anyway. So, I mean, that's a very, very important point. A couple of quick questions from the audience. Zora wants to know, what kind of water do you drink? We get water questions a lot, and I always like to get different people's take on that. Anything special about the water you drink?
No, just water. And that's really what I drink. I have 1 cup of coffee black in the morning, and then I just drink water. So those are my only two. Tell me, what water do you drink, and why is that a question about that?
Well, it's interesting. We actually had a story on water. I actually had my house water tested, and in Houston, some municipalities have terrible water. There was radiation, lots of chemical toxins, pharmaceutical agents, etc. I had to invest in a whole house water filter. I think so.
Okay, well, that's why you're asking.
We're in Houston. And so we had this big talk on water, and I think it's one of the issues, because I see patients and they follow wonderful lifestyles, and sometimes there's a missing piece. And so we're starting to look at other areas, and water is one of the one, and we often talk about that from time to time. Okay. Now somebody asked about artificial sweeteners. Anything you want to comment on that?
Yeah, I don't use any artificial sweeteners, and I don't recommend any of my patients use artificial sweeteners.
Now, a lot of questions about where do we find the movie. Now, let's get into that. I know you're going to get to where do we find the movie, but you felt moved to do a documentary. Now, again, we do things out of the box here, and this is way out of the box. So you became a movie producer. Tell us about that.
Well, because to me it was incredulous that the one intervention, the most important intervention, we know that the number one contributor, the root cause, the number one root cause contributing to this chronic disease epidemic is our poor diet. It's now, poor diet has surpassed smoking. So our diet is worse than smoking, right? And this is so powerful, and it is incredulous. And I couldn't understand how it was that this wasn't the most important lesson I learned in medical school, right? And so I think this is a huge opportunity for us to create change in the world by assuring that moving forward, we create the curricula in U.S. medical schools, right? Because the way we train doctors today is based on this model of pathogenesis. So we teach doctors, they become really good at understanding disease and illness. We become good disease detectives, right? Yep. We're good at taking a history of physical, we draw blood and imaging studies, all in an effort to collect clues and then ultimately make a diagnosis. And once we have a diagnosis, our treatment plan includes a pharmaceutical agent, a procedure, or a surgical intervention. And all of that is important. Pathogenesis is important, and we need to do that. But that's only half the story. The human health experience, the opposite of pathogenesis, is what we call salutogenesis. And salutogenesis is the study of health and well-being. We don't know anything about that. We represent health and well-being in our community, and we don't know anything about it. And so salutogenesis would mean module rather, medical school that include nutrition, physical activity, stress, sleep. How do we counsel our patients on behavioral change? These are all really important lessons that we need to add to the medical school experience. And by the way, not just medical school, all healthcare professionals, right? Nursing schools and anyone who's in contact with the patient. So salutogenesis should be the foundation on which we build all else. So all doctors should understand. And there should be emphasis placed on prevention. There's no value placed on prevention. And prevention should be our priority, right?
Yeah, exactly. So the Code Blue, I guess Code Blue, tell us about Code Blue. I mean, I remember when I was at the ACLM in 2016, you guys had your cameras out and filmed.
So Code Blue, sheds light on this lapse and then offers a solution. And the solution is lifestyle medicine, right? It's plant-based nutrition and empowering patients to really control their personal health outcomes by changing their behaviors. And we know, Baxter, that 80% of chronic diseases are preventable by modifying our behaviors. That the scientific literature is overwhelmingly supporting that statement. So if we empower patients, we spend $3.6 trillion every year in healthcare in this country, and 86% of the dollars we spend are spent on the management of chronic diseases that I just told you 80% are preventable. Isn't that crazy? That's maddening.
Yeah, it's very crazy. I don't want to be a conspiracy theorist, but I don't think that's accidental. I think there's a force that's pushing us in that direction. And I don't want to go.
We have to push stronger in the opposite direction, right? So that's why, meeting you at ACLM and then coming down to Houston and filming you and your work, and really empowering and just coalescing our voices, so that the world hears us. And that's really the dream of the documentarian, right? To shed light on a lapse in society and hopefully bring the masses together to create change. And that's what we need to do. And, right now we're in the midst of, I know what's first and primary on all our minds is the coronavirus pandemic, but think about how the coronavirus pandemic has intersected with this chronic disease epidemic.
Yes.
The CDC put out the morbidity and mortality report on June 15th. At the time, there were 1.8 million Americans infected, 103,000 deaths. But what we learned was if you had a chronic disease at the time that you were infected with this virus, you were 6 times more likely to be hospitalized and 12 times more likely to die.
Yep. Yeah, the thing is that the coronavirus I'm not trying to belittle the virus. There's some political issues there, but in essence, it needs a chronic illness to do its damage, by and large. Yes, there are a few exceptions of people who are apparently healthy, but by and large, coronavirus really needs a cofactor, because most of these people have what we call oxidative stress, and you get the infection and it just tips you over. And so if you control these chronic illnesses, you really will improve people's health. And Dr. Williams, somebody shared the data with me the other day. He did an analysis because there was a talk about the increased deaths of Black Americans with coronavirus. But then when they control for chronic illnesses, the actual hazard ratio was 0.83 compared to the population. So it's actually lower if you control for chronic illness. So these chronic illnesses are really
right. That's why it's so important right now. So I think right now this is our call to action, right? So this could be the silver lining of this horrific, historic moment where we're suffering with this coronavirus. This has to be the silver lining here, that we bring change, particularly to minority communities. I'm Cuban, so when you looked at the data from the CDC, 33% of those affected were Hispanic and 22% were Black. So our communities, our minority communities, are really suffering, and it's we must bring this to the attention of our communities and empower them. And create and change in those environments. And I know this is not easy, and there are socioeconomic challenges that we need to address, but we need to come together and bring everyone to the table, politicians, whoever, CEOs of hospitals, insurance companies, but we need to address this lapse and these food deserts where there's no access to fresh fruits and vegetables. It's very complicated, but it needs to be addressed.
Last thing, a couple of last things. One, where can they find the movie Code Blue? It's an excellent documentary. I want to say I highly recommend it, not just because we're filmed in it, but they do an excellent job of chronicling not only Dr. Stanczyk's life story, but the whole process of how we learn medicine and how we need to turn this thing around. So it's really important. It's a very important documentary. How can our listeners find it?
So it's if you go to our website, codebluedoc.com, there are several platforms like Amazon, Google Play, Vudu, and I just want to briefly mention my book. Over the past 15 months, I've been writing my first book. It's called What's Missing in Medicine, and the reason I called it that is because what I just said, what I didn't get in medical school, this book offers. So it's really addressing the 6 spokes on the lifestyle medicine wheel. into nutrition, physical activity, stress management, sleep hygiene, the importance of addressing substance abuse issues, and then social connectedness. We know that those amongst us who are depressed or isolated are more likely to develop a chronic disease and die prematurely. So I hope that the book serves as a roadmap to improve the quality of life of whoever reads it. And also for doctors and healthcare professionals, these are the missing pieces that you're not going to get in medical school. But until we fix that, we need to change curricula across the medical school. So that's really my hope, and what I'll be working on really for the rest of my career is really shedding light on this lapse and hoping that medical schools will change their curricula so that we can produce physicians that are well equipped and ready to deal with this chronic disease epidemic.
And can they pre-order your book on Amazon or?
They can pre-order the book, yes, on Amazon.
I'll put that in the chat as we close out. Well, guys, this is great. Thank you very much. This has been an excellent talk. And as we close out this evening, I want all of you to take this message to heart. If this is your first time, signing on to our show, I want you to be sure to subscribe and hit the little alarm bell so you'll get more information. Our shows are often packed with lots of information similar to what we have here. We talk about different approaches to treating illnesses that you may come across, and in the typical medical environment are given options that are only in the area of the pharmaceuticals and standard surgical treatments. But we want you to broaden your scope, broaden your outlook, and enhance your health. The diseases such as MS, which can be very, very daunting, doesn't have to be. And here's an example, and Dr. Stancy's example should be the rule, not the exception. And so please subscribe or like, but of course share this with as many as your friends. This is a very, very important message. And I've seen patients with MS in my clinic, even as a cardiologist. So this disease isn't a very rare disease. It may be somewhat uncommon or less common, but it's frequently seen. And so it's something that's very important. So again, as always, thank you very much for tuning in tonight. And we look forward to seeing you next Monday. Now, next Monday, I will be away, and we're going to have a rerun of one of our previous shows. I'm going to choose a favorite that you had before. And the week after that, we'll have a special guest. We'll have some wonderful guests lined up after that. I'll be taking my daughter to Atlanta. So we won't be live, but we're always going to be natural and fresh. So until next time, you guys keep it fresh, natural, and live.